hope I'm now on the screen again for a continuation on this topic.
Yes,
Can
please.
you see the presentation?
Yes, absolutely perfect.
Okay. To add to this case, the difficulty was also the drop foot in such a case, which makes that it's very hard for the patient to walk with the combination of deformities and the drop foot. And as such, I think when you correct the bone as good as that's possible, the bone always wins. So if the bone is corrected, you have a stable basis to continue from there. Very nice that you show me the now locked in walking video. This is a very nice lady, a very nice family, and I hope you can say hi to them, and that I'm very happy to see them again, even on video. Now let's go to slope corrections for ligament laxity. There is a different definition, different nomenclature on this topic. So we're looking now at the side view of the leg. This is out of Paley's Principles book again. You have different angles there, which we are not very familiar with, especially not on the femur. However, very important is to realize the method of slope measurement. The method of slope measurement takes into account that from anterior to posterior, you divide the distance in 5 equal distances. At 1/5 from the anterior part, you make a dot on the X-ray at 1/5 of the anterior part. And then the second dot is at the middle of the tibial plafond distally in the pure sagittal plane. From there, you draw a line proximal to distal, and the line of the slope of the proximal tibia angles to that. And that angulation from that line through the shaft, the mechanical axis, and the line which is parallel to the tibial plateau on the sagittal view is the posterior proximal tibial angle, and norm value is 81. You remember that case in the surgical planning talk? She had 51, norm is 81. From that, you can have a procurvatum if you have a femoral or a tibial deformity, which means that you have a flexion deformity. And if you have an extension deformity, it may be due to a bone abnormality which causes recurvatum of the knee. Then the posterior proximal tibia angle is larger than 84. So it's larger than the spread of the angles which are normal, considered normal. So for example, if you have a slope which is 90 degrees, so then you have, by definition, a recurvatum in that knee, considering that the soft tissues in the back are not scarred. So from that measurement, you can find out where the deformities are. So I recommend to you, go and find your reference values like I show you here in the publications on the sagittal plane deformities. Now look at this leg, and I first showed this picture, I will never forget that, in a talk on ASCA 2010. This was a talk on failed posterior cruciate ligament reconstructions. And I was just the odd duck at the end of the session. And I said, well, we all know this is a posterior tibial sag, and they're all ligament surgeons there in the room. But I said, this posterior cruciate ligament is totally normal. And then the room went quiet because I showed them this picture. This is a posterior tibial sag because of a recurvatum after a post-traumatic early closure of a tibial tuberosity growth plate. If that growth plate of the tibial tuberosity closes premature, you will have a normal growth in the back of the knee, and you will have a severely negative slope, and resulting of that is a posterior tibial sag. So sometimes what you see is not what you get. And this is a different way of thinking, to bones instead of ligaments. And if you can keep up with that, follow me through the presentation and always think of the bone. The bone wins from the ligaments. So here we are. This is a very important publication by the group of Philip Lobenhofer, then with Jens Agnes-Kirchner together. They performed a very nice investigation, changing the slope in a mechanical device after they had cut the PCL. So they were looking at what is the influence of a flexion, open wedge flexion high tibial osteotomy in reducing the tibia, which is posteriorly sagged because of a PCL insufficiency. And they gradually increased the slope and looked at the position of the tibia relative to the femur. Now look at this graph. On the left side, it shows PCL cut. Where's the tibia? The tibia is posterior with a 0 degrees of slope. If you only, so normal slope as a reference. If you only increase 5 degrees in slope, immediately the posterior sag is reduced and the tibia moves forward with only a 5-degree slope change. That means that you can replace the function of the PCL by only a 5 degrees of slope change. And of course, if you need more, the effect is stronger. And it was clearly shown by this group that a posterior subluxation of the tibia can be reduced by an increase of the slope. That was what I did in this Indian patient in the live surgery. I reduced that posterior subluxated tibia with a negative slope to a normal position with a fairly normal slope by an open wedge high tibial osteotomy. This is from Imhoff, the group of Imhoff, and they made some drawings to show that effect. If you have a negative slope, the femur wants to move forward on the tibia. If you have a increased slope, the tibia wants to move forward instead of the femur, and the femur moves backwards. Now we all know the situation which is drawn up on number C on the right side. If you have a high slope, your ACL is in danger, very much in danger. You have a much higher chance of rupturing your ACL. Now think of a high slope like that on the right-sided figure in the bone, and then that you want to do an ACL reconstruction. What is the chance that this ACL reconstruction will survive in a too high slope? Because the forces during stance and walking are against your ACL, are against your ACL graft. The other situation is in A, it's bad for your PCL graft if you have a negative slope. This is courtesy of Professor Philip Lobenhofer, a good friend of mine, excellent osteotomy surgeon, who gave me these slides, and I've used it a couple of times since then to illustrate the phenomenon that plays with tibial slope changes. The tibial slope in this patient was changed after a high tibial osteotomy, and here I show the importance of good x-rays. So this is the contralateral normal side. This is, well, not only one ACL surgery, ACL reconstruction. This patient had 3 failed ACL reconstructions. And in one time, as I was told by Philip, she didn't even succeed to her 6 months rehabilitation after the previous ACL reconstruction. Well, that's a disaster. What was the case? Look at this. The normal knee on the left side had a normal slope, even a low slope. The right side, you see the subluxation happening there. The femur subluxes posteriorly, the tibia subluxes anteriorly because of that very high slope, which was caused by a high tibial osteotomy performed the wrong way. So they increased the slope of the proximal tibia by the high tibial osteotomy. That was the cause that all these ACL reconstructions failed. So, very important, recognize the shape of the bone as a cause of your ACL reconstruction failure. This has been recognized. This is a systematic review of clinical evidence, which was published in 2017. The impact of osseous malalignment and realignment procedures in knee ligament surgery. Please read that paper. Very good group of authors of different institutions did a systematic review and found that, to say it more easily, the bone always wins. Your reconstruction fails if you do not look at the bone. What do I use to do these kind of surgeries? Well, you have seen some of the tools already in the live surgery. This is out of my armamentarium. I need some K-wires, I need calibrated chisels, and that's about it. And on the far right side, I cannot see, but the spreaders are important too here. And then, of course, the calibrated saw blades. Some of the other tools you do not recognize, probably you will see in the later presentations. But these are essentially the calibrated chisels, K-wires, that's what I use. If you look at slope-changing osteotomies, you have to realize that in your surgical technique, you have to deal with the tuberosity. Why is that important? Well, it's a big difference if you make your osteotomy and your correction distal to the tuberosity, where the bone heals not so easily, where you need all kind of plating because of large forces acting out there. If you are a plate surgeon, if you do like Elizarov kind of technique, X-fix technique, this is very often used. And they do excellent surgeries like that at this level. But this is not my preferred level of performing slope corrections. If you do slope corrections proximal to the tibial tuberosity, what you see is that with an opening wedge, but also in a closing wedge, you will change the height of the patella. And there's a warning here, because there are all kinds of publications coming out right now, specifically in the field of the ligament surgery journals, where wedges are taken out proximal of the tuberosity. So no touch tuberosity technique. And you have to realize if you take out a wedge, you will heighten the patella. It's only logical. And if you open that bone proximal to the tuberosity and you put in a wedge, you will end up with a low patella, a patella baja. So think about the patella position if you do sagittal plane corrections. The preferred method for me is to do a tibial tubercle osteotomy. And that means that you do a total tuberosity osteotomy, you reflect the tuberosity upwards, you mark where the tuberosity came from in the proximal part, and that's here, the proximal part, you mark it on the bone, so you can always find back where it was. And of course, then you have a gap here. But if you make a shallow osteotomy, that doesn't matter. You protect that leg anyways. This is an opening wedge. It's the same for me in closing wedge. I do not want to create a new pathology, as in deformity, when I do a sagittal plane correction. I don't want to mess with the extensor apparatus other than replacing the tuberosity back at the exact place where it came from, at the proximal part of that. And only then I can make sure that I'm not giving the patient a new deformity or a new pathology. So I'm not in favor of some of the publications, which are quite recent, on extension osteotomies, slope correction to benefit ACL reconstructions. And these slope corrections are above the tuberosity. That's a personal opinion, but it is, I have a population who need large corrections. Abu Dhabi population has very high slopes, and these corrections you cannot do above the tuberosity without creating a patella height problem. So what are we doing? This is what you saw in the video. This is the so-called biological plating technique. We make an oblique cut ending at the hinge point posterior, which is the PCL attachment. That's your reference point. So you aim your K-wires there, then you've taken off the tuberosity, reflected it upwards, you open up the bone, and then you do the so-called biological plating technique. This has been described also by the group of Lobenhofer, but also by Bonnet and other authors before. Biological plating is a very nice technique, and the whole rationale is, where do you want optimally positioned your plate? Where the plate position is actually the tuberosity position. So you use the tuberosity as a plate, hence the name biological plating. You fix it with screws. You can have a screw proximal. Most of the times I only do screws distally, and then these days I put a staple to get a hold of the graft and the bone on the medial and the lateral side. That's my normal technique. And this is an extension osteotomy. This is a high sloped patient. This is a revision ACL situation. And the slope is reduced by anterior closing wedge with a total tuberosity osteotomy. Many cases like that with much bigger corrections we do in the Abu Dhabi population, often combined with the famous Dr. Brown doing the revision ACL surgeries in these patients. And I'm only adding with an extension osteotomy. And that's the work for these patients. Now, there are other ligaments on the knee. So this is not slope correction, but just to show you how you can play around with ligament tension. What do you do with a chronic MCL laxity? As I know that many of the patients in India have varus legs, if you have a chronic MCL laxity and you cannot do anything with the ligament itself, do a small opening wedge osteotomy. Normally in opening wedge osteotomy, you have to release, like is shown here, you have to release that medial collateral ligament. Well, if you do not release it, you will tense it. So by a small opening wedge HTO, you can retension a chronically insufficient MCL. What about the lateral collateral ligament? This is from a publication I wrote in one of the books together with Bob Taichi. He said, well, what do I do with these failed high tibial osteotomy with these very high riding fibulas? They all have a lateral laxity. So if you think of tensing the lateral collateral ligament, think of a shortening osteotomy. Be careful in this area, but you can do that, a shortening osteotomy. That will easily tense that lateral collateral ligament. It's just a matter of thinking of bone instead of ligaments. So the ligaments are intact, but they're not working. You only have to tense them, and you can retense them with osteotomies. Some literature, open wedge high tibial osteotomy for posterolateral corner insufficiency. Look at the group of Laprade who published on that. 38%, almost 40% didn't need any second stage ligamentous reconstruction after such an osteotomy. And this is also an example about timing of osteotomy in ligament insufficiencies. This is a case of 15 previous surgeries in a multi-ligament injured patient. And she has been having surgery from all the high-level experts around the world. Well, this tibia and femur, for me, looks like cheese. We have a lot of cheese in the Netherlands, and we have a lot of holes in cheese, and we have a lot of tunnels and holes in that kind of bone. So if you want to go with an osteotomy, and she hasn't had an osteotomy, where's the osteotomy? In a multi-ligament failure after failure after failure case, which now has developed into a varus with medial OA. Maybe at some point, a osteotomy would have been beneficial to help the ligament reconstructions. It's just a question. It's been proven that osteotomies need to go first or go into combination with ligament reconstructions if ligaments fail. So consider to do osteotomies first before you do your ligament reconstruction, or combine. Because, and I state it again and again, the bone wins. Your ligament will fail. If you still have a high slope, your ACL reconstruction will fail. So please think about that. Don't forget the sagittal plane. The tibial slope has a direct influence on sagittal plane stability. Sometimes you do not need an ACL reconstruction anymore after you have corrected the slope. Osteotomies can reduce or increase the stresses on knee ligaments, and pay attention to the technical details. The patella height is very important. The tuberosity position is equally important. So think about that in planning your sagittal plane corrections. That's the end of this presentation.